Okay, good morning and welcome. It's the week of July 4th. Today's the last day of June, June 30th, 2026, and it's an extremely hot day out there, as you probably know. So let's get into it right away. So at this point, as we progress, so in fact, you know what? I'm gonna go ahead and just open the calendar real quick just to get locked in on that for a second. Okay, so we're roughly halfway through the semester. Oops. We're roughly halfway through the semester. By the end of this week, by July 6th, so by Sunday, believe it or not, we're going to be halfway through the semester. Um, Last week we started the brain, or we did the brain. We didn't get to the eyeball, so we're gonna do that when we're back together. We'll do the eye and blood typing. Um, I'm not sure if we're definitely going to do the eye first on Tuesday. Now, if we have time to do blood typing, we will. If not, we'll just pluck and GI can be done the same day. Um, so anyway, I may move pluck down here with GI, heart down here, and blood, everything moves down one. So anyway, regardless, next week we'll be back together and we'll be together 6 weeks in a row. The last week will be your final exam, and I'm still compiling that and creating that and getting that going. So I'll add we're most of you, I would say, about a quarter, maybe a third of you are done with the Module 2 / Unit 2 assignment. So several of you are in this area, which is fine. It's a good spot to be. I did submit midterm grades the other day. All of you are doing fine. So you should see a midterm grade somewhere in your My Gateway portal. Let's see. So anyway, today I want to discuss Unit 3 / Module 3, whatever you want to call it, the nervous system. And then next week when we're back together, like I say, we're going to be dissecting the eye and then believe it or not, starting into module 4. So time flies. The summer's a little bit shorter semester. It's about 2 weeks shorter than the normal semester. So anyway, so having said that, make sure that, again, there's really only one due date, that the August 15th. So that puts you again at about 7 weeks uh, still to get your work done. But yeah, you don't want to put it off too long. And like I say, your the final exam prep, I'm continuing to work on that. And don't forget the HESI prep tools as you go. Those may be helpful as well. I have Padlet boards in there. I mean, you're inundated, I realize, with information. So pick a lane, and if that lane is working for you, then stay in it. And you can always, get off on a few exits here and there and shop or, go to the rest stop and maybe pick up something else and get back on the highway and get back in your lane, but maybe with a few more tools. So, but yeah, if your lane's not working for you and you're stopping and starting and you're getting run off the road and you're getting pulled over and you're, running over animals and, you may need to pick a different lane. So anyway, figure out what tools and how you're kind of gaining a basic understanding of this. I mean, we're not asking you to understand the entire OpenStax textbook and everything you see in McGraw-Hill. You're just being exposed to the basics, and some of the basics, get a little bit heavier. And but again, we're not asking you to go too deep here. So you guys are all doing great. Let's take a look at the next unit assignment. So unit 3 lab assignment, this gets into the neuroendocrine connection. So we open that, and again, make sure that you're referring as needed to the YouTube video there where I discuss the details regarding labeling. All right. So again, this looks should look familiar at this point. I'm still waiting on a couple of the first one, the unit one assignment. Um, so so anyway, here you go. These are details. Some of these are familiar. We looked at these last week when we dissected the brain, right? Pia mater, subarachnoid space, cerebral spinal fluid, ventricles, cerebral hemispheres, diencephalon. We'll talk about some of those a little bit more today. But you could literally, I mean, all of you were in the dissection last week, which was awesome. It was great to see everyone there. I mean, this class is 18 students, and all 18 of you were there. So that's awesome to see. So, and you guys did excellent. There were squealing and squeamishness, and you guys all dove right in and took care of biz. So I appreciate that, and I look forward to our next one, which is going to be the eyeball next week. So anyway, there's more nervous system info throughout. Grammar. So David, great. Anyway, uh, and some cranial nerve stuff. Again, do you need to know all 12 pairs of cranial nerves? Yeah, probably not. Should you know a handful of them? Yeah, probably. Probably the ones we talked about: optic, optic, oculomotor, olfactory. We talked about the vagus nerve a little bit. Um, yeah, those are the big four, I'd say, and then trigeminal. A lot of the nerves have to do with facial movements, facial expressions. Um, Proprioception of the face. Because remember, nerves either are motor pathway, sensory pathway, and then in the cranial, we have special sensory pathways. So anyway, just more nervous system until we get right around. Well, these have to do with receptors. As you can see, the term "scepter" or receptor is in these. So that has to do with receiving something. So these receptors typically have to do with receiving information, whether it's temperature, pain, light, pressure, things like that. So so we'll see some of that. Let's see. And then we get into special senses. So there's some information on the ears and the sense of sound or hearing. And then we get into the eyes. So next week, when we dissect the eyeball, we're going to be looking at some of this stuff. The sclera, that's the whites of the eyes. And there's that word plexus again. Remember, it's like a bundle of blood vessels and nerves. Typically a nerve bundle, but there are usually blood vessels involved. The retina is going to be the location of all of the sensory receptors for vision. So the retina is going to be where we have what are called rods and cones. These are, again, specialized nerves that receive information. So we'll see the retina next week. It's going to be basically it's on the inside of the eyeball, and there's going to be this gel that basically kind of keeps the retina open. And then the retina is just an extension of the optic nerve. So we're going to see the optic nerve kind of pushes through the back of the eyeball, and then the retina fans out. And then there's going to be this gelatinous goo called vitreous humor that's going to kind of keep that retina so it stays fanned out. So we'll see that. There it is, Vit 121, vitreous humor. So we'll see that as well. Conjunctiva, that's going to be another little area, kind of going along with the sclera and the cornea. We'll kind of blend all of that together. So there's cornea up there. So anyway, we'll see some of these eye identifiers next week. And then that gets us into the endocrine system. So most of what you're going to see with the kind of a lot of terminology this batch, but now that's this is what you came for. So what you get for hormones or for the endocrine system starts right about here, 123. You're going to have what looks like about 35, 37 terms for the endocrine system, most of which are going to be the different hormones. So there are certainly a few of these glands we've already seen. We saw the pituitary gland last week. We saw the pineal gland as well. But anyhow, you're going to see some of the different hormones associated with the gland. So I tried to put them together. So you have the gland. Oh, by the way, hypothalamus is it's not technically a gland. It's like a region of the brain that does secrete some hormones, and it also secretes some neurotransmitters. It has all kinds of neuronal bundles in it. But the hypothalamus is linked, of course, directly with the pituitary, which we saw last week, and the posterior pituitary. These are the two hormones we see with that. And then the anterior pituitary, we have a handful of hormones associated with that. This is, remember, the pituitary is the master endocrine gland. Oxytocin is going to deal with uterine contractions. Clinically, they call it Pitocin. Antidiuretic hormone, or ADH, is going to deal with retaining water, maintaining fluid balance. So when the body's extremely dehydrated, the pituitary is going to release some extra ADH so your kidneys retain water. So the thing about endocrine system and hormones, there are target organs, target cells, I guess you will, if you will, for the hormones. So, pituitary releases the hormone oxytocin. The target is then going to be the uterus, for instance. So, one thing you could potentially do as you're defining these or researching these, I mean, you could copy and paste definitions. That's fine. Do whatever you need to do there. But you could also just, make little notes that'll help you to maybe remember some of the basics, like oxytocin, you know, uterus, or target is uterus, uterine contraction, stimulates childbirth, Pitocin. There's little buzzwords associated with this. Target here is going to be the kidneys. So you could maybe look at what the target cells and target organs are as you're completing these. But again, that's up to you. That'd be how I'd maybe approach it. All right. So anyway, there are several more associated with the pituitary. Then we leave the pituitary and we land on the pineal, which of course produces melatonin, which is your body's your circadian rhythm reset button hormone. Anyhow, then you have thyroid, and there are a handful of hormones associated with the thyroid, and then the parathyroid, adrenals, okay, and then this RAAS. You'll want to look into that briefly. Pancreas, insulin and glucagon, and then of course the ovaries and testes producing testosterone, estrogen, progesterone. So anyway, you could buzz through those how you see fit. And then, of course, our labeling. So you're going to have the neuron. So we'll look at some of this stuff today. The subdivisions of the thing about the nervous system, we're constantly separating it and dividing it into different sections. It makes it, believe it or not, a little bit easier to follow. And then some of these we did last week. These are some brain identifiers. So you'll definitely want to, I mean, you could potentially work on, I don't expect after one visit, you know, with the brain that you get that. But so anyway, name of indicated part. See, lobe, gyrus, sulcus. So this part, I want you to put, and this is for this. Okay. See, it says name of indicated part below. Here's the images here, or the illustration. And again, if you're unsure of what to put, always refer back to, because I do, it's a This is all cerebrum, but this looks like occipital lobe. You could maybe just put cerebral cortex here. Or you could put parietal region, frontal region. But anyway, that's up to you. You've got the brain stem, so you want to look at the medulla and then the pons, see how it kind of shaped like a P, pons for pouch, midbrain, hypothalamus, thalamus, corpus callosum. So yeah, if you want to go through those. And there's the spinal cord, some of the features of the spinal cord, and then just some fill-in stuff. There are the 12 cranial nerves. And again, you could keep it brief with your definitions here or your functions. Again, you want to indicate if it's sensory or motor or special sensory even. And then lastly, your ear, eye, and endocrine. So you could, it looks like a lot, but it's really not too bad. This is actually, I think, a lot smoother sailing with the labeling than the bones and muscles. There are just fewer things, and um, you know. Anyway, so please keep working on these or get started working on that. I know, like I say, about five or six out of 18. So about a third of you have submitted the Unit 2 one. And then I think around 15 of you have, I'm only waiting on a couple for the first one. So anyway, any questions, comments, concerns on that? Okay. And then, of course, your McGraw-Hill. I'm not, well, I don't know. Like I say, you can, let's come over here. We'll pull it up. Why not? McGraw-Hill, or we'll try to anyway. Let's see if it cooperates this morning. Most of the time it does. McGraw-Hill is pretty fantastic. And you'll be using McGraw-Hill for advanced A&P. Um, So you can register for that anytime. I think that's open. And then I'm also doing a pathophysiology web course in the fall as well. We only offer that once a fall, and the um, the dean prefers that we get 15 students in there, and right now they're about eight, which is good. So we're about halfway there. We're trying to get another 7 or 8 students in there because the college oftentimes, if a course doesn't run, then they won't offer it in the future. So that may be kind of one of those deals. So at least that's what I've been told by the dean. So they're trying to, anyway, we're trying to get as many students in all of our classes as we can, certainly. But yeah, if that's something that interests you, pathophysiology, it's 3 credit hours. I'll put out an announcement and a video about it sometime later this semester as a reminder. But if you have questions or anything about that, just let me know. All right, so let's get into. Looks like McGraw-Hill updated a little bit. They definitely did. So, yes, yeah, wow, they definitely updated. That's good. They needed to. They'd had kind of the same platform for I don't know, a couple of years ago. I think they updated it. So it was due. All right, let's take a peek at student view. Nothing should be any different on your end. And if it is different, it would generally be for the better, I would assume, for like usability purposes. All right, now I don't know how far along you guys are, but you should hopefully be entering into the Unit 5 nervous system, which is your part 3 of your packet. So, brain lab. So, this is going to be identification of brain features, just like we did last week in lab. And then spinal cord and spinal nerves lab, and then just a general overview of the nervous system with a little quiz there at the end. And then you open up into the next one, and you have the endocrine system APR, and then the quiz there at the end. And then finally, your Module 3 exam. Okay, so you have basically 4 labs to do in McGraw-Hill, and then the exam for that particular module. All right. So that's McGraw. And again, I don't know if you guys are doing or how you're working it, but just as a reminder, you can be completing a lot of your assignments kind of going back and forth uh, in McGraw-Hill. And divisions of the brain. And so this first batch is going to be some videos. Yeah, so you watch a few videos. And then the next batch gets into some brain anatomy. A lot of this information is what we looked at last week. Now, some of these, Falx, cerebelli, and cerebri or cerebri, you don't need to, I mean, obviously you're going to identify them, but, we didn't talk about these. It's probably because it's not you have so much to learn. So we try to pick our battles. But anyway, for the most part, though, these are features that we saw last week and more of the same. And if you didn't get it on that one, they're more of the same, different views and perspectives, and then a quiz. So again, McGraw-Hills aren't too shabby. You'll be able to do those as well as complete your several aspects of this. All right. So anyway, I'm going to get off of that. You guys, at this point in the semester, I would hope by week 6, have a pretty good idea of how you're going to be approaching your unit assignments and your McGraw-Hills. All right, so let's discuss. Let's talk about the nervous system a little bit. Oh, wow, look at that. October 23rd. Interesting. All right. So let's get her done. I don't know how long I'm going to go, but I just want to cover a handful of items with you, and then we'll see what happens. All right. In fact, hold on a second. What time is it? Maybe, all right. I'll probably go about an hour, maybe till around 11, maybe a little longer. All right. All right, so nervous system cells. Again, we start every new unit, every new body system by discussing cells and tissues. So here we go. The nervous system, and again, the cells, that's where the action happens. So when we analyze the structures and functions of cells, we're really seeing a lot of what the entire system is doing. So the function of the nervous system is, and the endocrine system, we put them together generally, is to communicate. So that communication pipeline is going multiple different directions. There are different pathways of communication and information that are flowing through the body. And again, this information is directed ultimately to the central nervous system, and then that's the sensory aspect. But we're also directing information away from the central nervous system in the form of some sort of motor response. So stimulus comes in, sensory, and motor goes out, which is going to be that response. So stimulus response, stimulus response. And again, the nerves are the pathways that this communication information its information is communicated within. So generally, when we're dealing with the nervous system, it's 3 structures: the brain and spinal cord, which is really just one structure, and then the nerves, which we saw last week come off of the brain as well as the spinal cord. And again, we have 2 pathways coming in, one pathway coming in, and one pathway going out. All right. So communication, that is the key to the nervous system. That's what it's doing. It's trying to keep the organism in homeostasis. It's trying to, or at least within those ranges, it's trying to keep the organism balanced. Okay, so uh, you know, generally speaking, our organs operate under these fairly flexible ranges regarding, blood pressures and heart rates and body temperatures and how much of a specific enzyme or how much of a specific hormone or whatever it is that's being produced. Uh, this, the nervous system is and the body systems collectively have these ranges that are generally established throughout and have been established through evolution and adaptation and through time. So, so anyway, our bodies are responding to basic stressors the same way today as really they would have thousands of years ago. The bear jumps out at us 10,000 years ago. A bear jumps at us today. The response is going to be similar. The communication pathways that are receiving that information are going to trigger all kinds of responses. And these are going to be stress responses. So generally speaking, our body's in hopefully in this nice kind of homeostatic vibe, and then certain stimuli come in that may put us out of homeostasis temporarily. And then again, once the perceived trigger is over, then hopefully we bring everything back into these homeostatic ranges. Now, some of the triggers nowadays are going, and historically, come in many forms, not just what we see or what we hear or what we smell or even what we taste or what we feel, but they come in all kinds of other forms. It's the chemicals in the foods and beverages that we consume can alter our physiology and can communicate signals to the nervous system through chemistry in the digestive system that we need to elevate the heart rate or we need to slow the heart rate down. Um, so, for like caffeine, for instance, and certain sugars certainly are going to create a potential blood pressure spike and an elevation in heart rate and body temperature and other things like that. So, some folks have allergic reactions, certainly to different foods, beverages, or other external exposure. So, like creams or ointments or gels or whatever. So, the body's response pattern to what it's receiving all relates to the neuroendocrine connection. So, and again, it's the nerves that are receiving the information, delivering the information, as well as sending the response that the brain and spinal cord determine is appropriate out to what we call the effectors. So here we see the spinal cord and brain. It's kind of a greenish color. This is going to be, again, one unit, even though we discuss it separately. And then we, of course, see all the yellow coming off all the different nerves. And we call that the peripheral nervous system, where the nerves are, and the central nervous system, where the brain and spinal cord. So that's important. It's very basic. But what makes up the central nervous system, the brain and spinal cord? Okay. And again, the nervous system's organized in a way that it's going to be going to best be able to communicate these changes that it detects. So again, whether it's these receptors are in the skin, whether they're internal, whether they are in the special sensories, the eyes, ears, nose, mouth. The idea is their location is prime and appropriate for detecting the changes that are occurring. And again, we see what are called external receptors and internal receptors. So external receptors are the ones that are generally dealing with the skin and sensations on the skin. So a lot of temperature receptors, a lot of pain receptors, pressure receptors may be located in the skin as extero or external receptors. Then, of course, we have receptors inside the body in our internal organs that are going to be delivering information or sending information that's going to oftentimes relate to inflammatory issues that may be occurring internally. So again, generally speaking, our body's organs and tissues and fluid compartments, they're all arranged in a way that, if there's pressure placed in an area that shouldn't be extra pressure, there are going to be nerves that receive that information that, hey, something's going on in here. This isn't supposed to be here. This happens like with a sprained ankle or something, right? You roll your ankle, and then what you're doing is kind of breaking apart some of the tissue, some of the smaller regions of the and areas of the tissue, regarding some ligaments, usually, maybe some just other types of connective tissue, some fascia, maybe some tendons, but usually ligaments and some fascia down there that get overstretched. There are a lot of little capillaries around those areas that get broken or breached. And so then, a bunch of blood is going to flow into this area where there usually isn't blood. And so you're going to have this buildup of fluid in the ankle where there isn't normally a buildup of fluid. Well, there are nerves that sit in there, and normally you don't even really recognize that there's any problem in the foot or the ankle until there is, right? And then that pressure builds up and it's tapping on the nerve, and then the nerve sending a signal to your brain saying, ouch, ouch, ouch. This hurts. I'm feeling pressure. I'm feeling pain. Multiple things happening potentially. And so that's why we say, well, you need to ice it. So the ice will kind of close off and shut some of those capillaries down so they're not just continually releasing fluid into those compartments, causing all that swelling and inflammation. So we want to bring the inflammation down. And then you bring the inflammation down, then the nerves are less being attacked, right? They're not being pressured by all that excess fluid in the surrounding tissues. So again, internally, nerves exist to tell us that usually there's some sort of an inflammatory issue going on. And when we talk about inflammation, we're generally thinking, there could be an infection, there could be some sort of physical, ailment or issue that created the inflammation. But usually, those two things are definitely something that we're looking at when it comes to inflammatory conditions. We, of course, have autoimmune disorders that can potentially create inflammation as well. So, but anyway, the nerves are picking up any changes in the internal or external environment. All right. So all of these nerves are detecting changes in the environment. That information is getting sent to the central nervous system. And at this point, depending on the strength of the stimulus or the intensity of the stimulus, some of that information will go to the spinal cord, and it'll just stop there and elicit a response from there. As opposed, I mean, it'll still send information up to the brain, but sometimes with really intense stimuli, like if you touch something really hot or really sharp, and you pull your hand away really fast, that's because we have this simple reflex arc that'll just go right to the spinal cord and then right back to the effector to get you to pull your arm away. So we can involve just the spinal cord sometimes for basic reflex. A lot of our posture and what we call proprioception is going to be uh, coming from your peripheral nerves and just to your spinal cord. So the brain is involved at all times, but we don't necessarily have to. Include it for everything that the body is doing. All right. So anyhow, as we go, we see already that we're doing these divisions of the nervous system, right? We started with here's the nervous system, and then we separated into central versus peripheral. So that's what we see here. The CNS is the central nervous system. That simply means brain and spinal cord. And then the other division is the PNS, which stands for peripheral nervous system. P for periphery, like away from the center. Okay, and we have two sets of peripheral nerves. We have the cranial nerves, 12 pairs coming off of the brain, and then we have 31 pairs of spinal nerves coming off of the spinal cord. Now, we can divide this peripheral nervous system further down into two separate pathways. And we talked about this last week. I've talked about it already today. Uh, but remember, as soon as we're locked in on the peripheral nervous system, which whenever you hear that, your brain instantly needs to think nerves. Just like when you hear central nervous system, you instantly need to think brain and spinal cord. Okay, so at this point, we're focused on the peripheral nervous system, which is nerves. And so then we're going to divide that into either motor pathways or sensory pathways. Okay, so the PNS, or the peripheral nervous system, can now be divided further into what we call the afferent division with an A, that means sensory, or the efferent with an E division, which has to do with the motor or the response pathway. Okay, so again, the nerves are going to have two potential pathways, one of which is going to be sensory and one is going to be motor. We've discussed this. We're discussing it again, but now we're going to add a couple of new terms, afferent and efferent. Afferent simply means sensory, efferent means motor. And efferent is we also have seen the term all the way back in week one when we talked about homeostasis, what are called effectors. So EFF, so effect. So an effector is always a muscle or a gland. So, and that's going to be a motor pathway that's plugging in to the effector. So the efferent with an E pathway plugs into an effector, which is going to be a muscle or a gland. And remember, muscles are either smooth, skeletal, or cardiac. So when we say plugs into a muscle, it could be any of those three. Okay, so the efferent division is the motor division. Motor means movement, means muscle. MMM. Efferent, motor, movement, muscle. Okay. So these are going to be, again, potentially cardiac, skeletal, smooth, muscle, but they could also be glandular. So this could be a sweat gland, which we call sudoriferous, the fancy word. They could be oil glands, which are called sebaceous. They could be earwax glands. They could be, it's like the stimulus is, lots of noise, boom, 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 work at the factory or just listen to a lot of music, headphones, whatever it is, the response often is going to be some protection for some of that sound wave that comes in. So the ceruminous glands, which are the earwax glands, pump out more cerumen. So stimulus is lots of sound, response is here's some earwax. Okay, just like the sweat glands. Stimulus is it's hot in here. You just go outside, right? For even just a few minutes, and your body will start sweating because the way you release heat is through radiation first. So your body is feeling this 90-degree temperature, and so it doesn't matter what the temperature is as long as it's below your body temperature, right? So below 98.6, you are going to radiate about 70% of the heat of your body because your body's going through all of these metabolic things, right? Your heart's beating, your muscles are moving, your digestive system's doing its thing, right? There's blood vessels are doing things. So your body's creating and generating, not creating, generating a lot of heat. And so we don't want to retain that heat. We have to release it. So basic physics says through radiation, we're going to lose a lot of heat. So heat travels from high temperature to low temperature. So again, in the body, it's normally 98.6. Outside the body, it's normally lower than that. So naturally, heat from in here is going to radiate off of the body and into the atmosphere. Now, another way we can eliminate body heat is we can sweat, or we can squirt water on somebody. So by putting water on the skin in hot weather, what that water will do is it'll evaporate into the air. And when it evaporates, it actually is pulling heat off of your skin with it. They call it evaporative cooling. So that's why you don't want to cover your body up with a bunch of layers or any layers, really. Um, you want your skin to be able to breathe, and you want to be able to sweat because that sweat is evaporating and it's taking heat with it. All right. So those are your two primary routes of heat homeostasis or thermoregulation. So on a day like today, if the temperature is above 98.6, the real feels like 100 degrees or 100, and yesterday I think it was 101 or 103. So again, basic physics for heat and thermodynamics says heat always goes from high temp to low temp. Well, now if it's 98.6 in here, but out here it's 100, where's the heat go? It goes on to you. So you're not going to be able to radiate heat off of you because you're absorbing the heat. So you have one other option. Well, you have a few others, but your second option is to sweat. So your body will instantly start sweating. You'll start pouring sweat, oftentimes in this type of weather because it's above 98.6. So as you're pouring sweat, it's evaporating off of you and it's taking heat with it. So anyway, yeah, you have to now water moisture also moves from where it's wet to where it's not wet. Just like heat moves from where it's hot to where it's not hot. Water, moisture, sweat moves from where it's wet to where it's not wet. So in the atmosphere, when it's drier, it works. So a dry heat works better for you, like Arizona, because what you're going to do is evaporate the heat through sweating because the air is drier. But you go to Florida, or if it's up here, if it's like 100% humidity, it's all, the sweating, you're not really losing the sweat. It doesn't really evaporate. It just kind of stays on you. So then your shirt, your hat, everything is soaked. So yeah. And that can be dangerous, right? It can be very dangerous for especially elderly folks or the two special populations for age, the younger buggers and then the older buggers, they are at highest risk when it comes to, um, some sort of heat stroke or inability to regulate temperature properly. So yeah, air conditioning, hydration, all of that is extremely important because even in dry conditions and high heat, you're losing a ton of water through sweating. You have to rehydrate, of course. So anyway, that's kind of your lesson for applicability for thermodynamics on a hot day like today and why you sweat so profusely. It's going to be this way most of the week, from what I can tell. It's supposed to rain though. Uh, Possibly tomorrow, definitely Thursday, and possibly Friday. All right. So anyway, afferent, efferent. Sensory comes in, motor goes out. Afferent, sensory, efferent, motor. All right. And then we can go even further and assess kind of what this peripheral nervous system, not just with its sensory and motor pathways, but we can also break the peripheral nervous system into being somatic and what we call autonomic. So these nerves sometimes, as we're sitting right here, we're in control of the movements of the activities of the actions of the responses. So we call this somatic nervous system relating more to skeletal muscle. So when I'm moving around, I'm talking, I'm grabbing a pen and I'm writing things, I'm typing, I'm holding my head in my hand, I'm folding my hands, I'm eating food, I'm driving, whatever it is that involves your skeletal muscles and movement, we call this somatic nervous system. Soma means body, by the way. So the somatic nervous system is more or less going to be kind of your voluntary aspect of the nervous system. So we have control, for the most part, voluntary control of the somatic nervous system and over our muscles. So um, now there are, there are some aspects of skeletal muscle called proprioception that, we don't necessarily consciously control. So, when it comes to like posture, now I just controlled how I was sitting, but at this point, I don't have to keep telling my muscles to stay somewhat contracted. Otherwise, I'll do this. And then I have to say, all right, contract, and then I'll do this. I can't, none of us have time or energy to do that all day. So the body has a way of, in essence, just keeping itself upright, keeping our facial muscles, for instance, from drooping, keeping our arm and skin from drooping. So this is called proprioception. Now, proprioception is more of an automatic kind of a deal. So the other aspect of, but anyway, even though it's somatic and it involves skeletal muscles, there is some automatic aspect to, and I should say involuntary aspect to the skeletal muscle system. But for the most part, when we think of skeletal muscles, we think of voluntary movement and the somatic nervous system. Okay. So if we have damage to a certain area of the somatic nervous system, it could inhibit, our ability it could inhibit motor skills, we say. So motor skills are part of your somatic nervous system. So if we have decreased motor skills or hyper motor skills, right? Remember everything that we want to retain or maintain kind of this balance, this window and range. And when we're not in this range, we're either hypo or hyper. And both can be equally deleterious or damaging, especially over time, to the organ and potentially the organ systems and potentially the whole organism. So that's again why it's so important to try to maintain homeostasis. And again, there are acceptable ranges. Some of our patients and some of us, we create new set points based on different stressors and lifestyle changes and exposure and things like that. So clinically speaking, our goal when we're doing, vital signs and checking, doing our intake with the patient, we're really trying to get a gauge and an idea of what their homeostasis is looking like. What's their body temperature? What's their blood pressure? What's their heart rate? What's their respiration rate? Even what's their pain levels. Again, that's subjective, but if they're at the clinic and they're not there for just a regular physical or a checkup, they could have, if their pain level is high, that may explain why some of these ranges of vital signs are a little bit off. They might have high blood pressure, high heart rate, a little bit of a body temperature issue. Those could be due to the fact that they've got some sort of issue going on that's put them a little bit out of homeostasis. They could have an infection. They could have some inflammation. They could have some sort of physical injury or some sort of trauma internally that's occurred that's creating inflammation that's leading to pain. But either way, the patient is not feeling, if they're in your clinic, oftentimes they're not feeling well. So they're out of this homeostasis range and they're up here. Now, if it's an acute issue, whether it's an infection or an injury, whatever it might be, we can hopefully take care of it, and within days or weeks or months, everything takes care of itself, and they're taking care of themselves, and all things end up being fine in the end, and they get to go on with their lives. But there are instances where that's not the case, where the individual has been, has their body system, their homeostasis is now at a new set point. So they live in a new normal. And so it may take a little bit long, and that's not doesn't mean it's healthy. So their normal blood pressure, normal heart rate may be up here now. So we need to work to get them, and they need to work to get themselves back into what's considered more clinically normal ranges for homeostasis. So that's a lot of what we do clinically is we're looking at the nervous system. We're assessing, the vital signs and evaluating what may be the issue here through a series of basically collecting data. Some of the data is subjective, of course. We're going to be doing what are called SOAP notes, in essence. Subjective information is, why are you here today? Are you in pain? Where's the pain? That type, just subjective. How do you feel? A lot of what they're telling you is going to be subjective. Now, it's not that it's not objectively true. It's not that they're lying to us. It's just that we are viewing them as an individual, as a subject that has some specific perceptions of what's going on with them and why they're here. So that's just taking notes on the intake. Now, the objective part comes with, the vital signs, getting actual numbers. So we're going to weigh them. We're going to maybe take their height to get kind of maybe a BMI vibe, even though that's not the best tool to determine health, but we do use it. So we might get some weight, maybe height, body temperature, blood pressure, heart rate, maybe a little bit of respiration rate. We may put the pulse ox and get a pulse oximeter reading on them. So it's just some real non-invasive, very basic numbers. And you guys have all been to a clinic on the patient side of things, so you know exactly what I'm talking about. And from there, the physician comes in and takes what they have, what the data we've collected, and look at it and say, all right, well, let's look in the eyes, let's look in the ears, let's look in the nose, let's look in the mouth. Let's do some basic reflex, check the knees and right. So we're gathering, so the physician's gathering information as well, and then ultimately trying to figure out why this individual's homeostatic is having homeostatic issues, basically, and are these issues chronic or are they acute? And a lot of times we can tell from the chart. Is this someone? Are they in here all the time, or do we never see them, and now they're here? They express that they were feeling fine, and now they're not, and it's cold or whatever. We can see that may be what it is, send them on the way, maybe a prescription, they get better, we may not see them again. That's hopefully, for the most part, that's the best case scenario with them. But some patients come in and we'll see it when we do advanced A&P. We do a lot of case studies. Each week we do a case study and we analyze what's going on with Mr. Smith or Mrs. Jones. And so, yeah, a lot of intake and a lot of data, a lot of numbers, and trying to basically you're a detective or you're playing, you're one of the detectives in a bigger group of detectives. All right. So the somatic nervous system, again, this is going to be voluntary. It's, has to do with moving the arms and legs and body. And so, if someone has, movement issues or strength issues, gripping issues, those are again things that we look at in the clinic when we're trying to assess the health of the entire organism, and certainly the health of the nervous system. Because one thing we know as physicians is that the nervous system plays is kind of the main body system. All roads go to and from, or go to and away from the nervous system. So yeah, we're trying to get that in order. And forever, even to this day, a lot of the physical stuff that we're talking about here, plays a role in the emotional brain too, and the thought patterns as well. So behavior and just physical stuff that with that, that's what we're into mainly at the clinic. But there are other layers, right? There's an emotional layer, there's a mental layer to this, a spiritual layer even. So I mean, and that obviously that's an area we don't even really touch. Like the clergy and the churches and the temples and the shrines, like they're that's the group that handles spiritual distress, right? So now emotional and mental distress, that's, another area, right? That's psychiatry or psychology and so you have all of these kind of siloed, kind of separate areas of health that unfortunately don't always connect with one another. And so that we can't ever discount or eliminate those aspects, right? Mental health today is huge, and emotional health is huge. Emotional intelligence, right? So again, the perception of stress and how we cope with stress, like these are all really big deals. PTSD, trauma bonding, trauma hoarding. There are just so many things that we see clinically that manifest that are almost exclusively tied to an individual's past and their perception of stress and how they cope with stress. So coping skills and self-worth and self-awareness and all of these different layers of the existence of that individual that have led them to our clinic because they've got a tummy ache that won't go away, or they've got a weight gain issue that they just can't figure out, or they've got a constipation problem that or they're chronically congested, or they have trouble with breathing. I mean, so by the time they get to you and me, it's all physical, 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 physical. But unless we encourage them to encourage themselves to look a little deeper, dig a little deeper, and find out who they are, then it becomes a real challenge. So I mean, it's challenging enough, right? Just dealing with the physical stuff that we see in front of our face. So it is important to understand that we can't discount the health of the individual, the physical health of the individual, being linked with the emotional and mental health of the individual. They're all part and parcel, and then that ultimately leads to the spiritual health, right, of the individual, the organism. So, but again, we work with what we have. We work within our lane, but understand that there are many physicians out there, and there are many areas and branches of medicine out there that do take the entire being as relevant. So a lot of osteopaths, DOs, they're called, a doctor of osteopath. Sounds like they work with bones, right? But in fact, doctors of osteopath really get into multiple layers of the existence of the organism. So they go a little deeper than just the physical stuff. They may have a lot of DOs have a little bit of background in psycho stuff, psychotherapy, and the mental aspect of healing, as well as the emotional aspects. And I'm seeing in Wisconsin, I'm seeing it all over the place, in Illinois especially, and Wisconsin, Florida, New York. The DO is every bit as recognized as an MD nowadays. And in fact, there are a lot of DOs that are working in Wisconsin in family practice, as well as their DOs can do we can perform surgeries. So a doctor Chicago has one of the premier universities in the world for DOs. So we tend to see more of them in this area because of that. So if you are working, if you are interested, when you're working clinically in more than just being a pill pusher, you could potentially work in a clinical setting with an osteopath or with DOs. And again, most nowadays I'm seeing DOs and MDs working side by side everywhere. And again, they're still a doctor. Forever and a day, MDs were kind of the poster for being the elitist of care and medicine and country clubbing and all of that stuff. Well, nowadays we've got a lot of other different options. DOs have been around for a long time. They've been around since the 1800s. Chiropractors, a lot of people are turning to chiropractic for certain things. DCs are called doctors of chiropractic. And some doctors of chiropractic do more than just crack bones, right? Some chiropractors actually get into the holistic aspects. So they look at more than just, you know, well, you've got a high body temperature, high heart rate. It looks like you got a cold, so here's some antibiotics, right? They might go a little deeper than that. They're naturopaths, NDs. Naturopathic doctors are less recognized. A lot of insurance doesn't pay for their services, so a lot of people don't utilize them. Um, so generally speaking, that's how people approach their care is how it's going to be paid for. And so all insurance companies have, in essence, a list of providers that are in their network or not in their network, as well as a list of services that they cover and how much they cover and what they don't cover. And so nowadays, a lot of insurance does cover chiropractic treatment. A lot of insurance under that will then cover massage therapy under chiropractic treatment. A lot of certainly covers doctors of osteopath and whatever they can do for you, which is a whole number of things. So just keep that in mind, both as a patient and certainly as an employee and as a worker in the healthcare field, is that you do have a lot of options. All right. This area here, autonomic nervous system, this is the spot where what we're talking about on the clinical level regarding vital signs and treatment of physicalness is coming off of this. The autonomic nervous system is another branch it's part of the peripheral nervous system and specifically part of the efferent. So again, we had central and peripheral. And then we have off of the peripheral, we have this motor versus sensory. Well, off of the motor pathway, then we have the somatic vibe, which is voluntary motor, versus the autonomic vibe, which is going to be automatic or involuntary. So we generally think of cardiac and smooth muscle as being regulated automatically. So the efferent division of the autonomic nervous system is going to be delivering information basically to the heart, to the blood vessels, to your endocrine glands, to the digestive tract, to the urinary tract, to the reproductive tract. So basically, everything in the body that isn't a skeletal muscle is going to be plugged in with this autonomic nervous system bundle. Now, we need the heart to beat all the time. We need the diaphragm and the lungs and the kidneys and the liver and the spleen and the gallbladder and the pancreas. We need all of these organs to be doing something at all times. Now, when they're when all of these organs and organ systems are operating under a quote unquote normal, balanced, homeostatic vibe, we say that is part of the parasympathetic pathway. So that second bullet down, that's technically the third bullet, but the second sub bullet down there on parasympathetic division, that relates directly to all of the nerves that are keeping your heart rate regular. They're keeping your body temperature regular. They're keeping your respiration rate regular. Okay, so 98.6, 120 over 80, 60 beats per minute, like all of those normal ranges occur because of the parasympathetic pathway. Okay, so the parasympathetic pathway is what we call rest and digest. Okay, this is basically, I don't think, I don't know what any of you are doing right now, but hopefully you're not under much stress at the moment. Hopefully you're chill, and cooled off in a nice environment, and you're sitting back, relaxing, and taking some notes, and everything's hunky dory at the moment. At least right now in this minute. It's because your parasympathetic pathway is overriding everything else, which it should. This is your, um, yep, all things are go. Okay. Now, as soon as a stressor hits, and that stressor could be external, it could be, oh no, my air conditioner just went off. Uh, Somebody left the window open. Now there's a bee or some mosquitoes in the house, and now all this, right? So now my chilling out, hunky dory, just kind of present right here. Nothing big, nothing small, everything just right. It's like Goldilocks. Then boom, something happens, right? Uh, it could be something as simple as a knock on the door triggers my dog, and now I've got to deal with somebody that I wasn't expecting, right? It's a door-to-door roofing guy, or want to pressure wash your siding, or I don't need to deal with that because it took me out of this and put me there, right? So a sound can set us momentarily out of our parasympathetic vibe. But oh yeah, boom, I got triggered by a noise, and my heart rate went up a smidge, my blood pressure went up a smidge. That's called the sympathetic pathway. That's the stress pathway. But then I take in that information and then decide, right? At that point, that's when you decide, you start making choices. You know, am I going to compound the stress and add to it, or am I going to just do what I would do and get right back into what I can control? I don't need to answer the door. I don't give two hoots about siding or roofing at this point. I'm busy. Um, my air conditioner, as far as that goes, hopefully it'll come back on. I can't worry about that at the moment. I'm going to go shut the window, or whatever, keep the bugs out. All of these things that you can decide to do to minimize or eliminate that stress pathway from accelerating. So we can't be triggered by something and then stay there. Today's the last day of the month. Some people are, we all have bills to pay. So maybe, you look at your account and you're like, oh God, I got bills to pay and I'm not ready. So, those are stressors too. And those are more realistic as far as like every day, moment to moment, minute to minute stressors, right? Financial stress, especially nowadays. I mean, you guys are in school, you're working, you've got bills, you've got food, you've got whatever you got. I don't know. So regardless, what you don't have is just oodles and oodles and oodles and oodles of money, probably. And so that even people with oodles, 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 oodles of money are still thinking about their oodles of money, right? So they're still stressed out. So it's important. It's imperative for you to retain, again, attain, maintain, retain, or whatever it means to attain it, your homeostasis. Find that get that parasympathetic vibe going and live there. Don't live in sympathetic. Sympathetic life is, oh my God, the sky is falling. What if, 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 what if I can't pay this bill? What if I die tomorrow? What if my husband or wife dies tomorrow? What if my kids die tomorrow? What if I have to go to work and somebody, doesn't like me? Or what if I have to deal with, what if I'm driving? And, if you live in that realm, you're going to be at the clinic, not as a worker, but as a patient. You're going to have heart issues. You're going to have cholesterol issues. You're going to have blood pressure issues. Because your body is perpetually in a sympathetic state. And sympathetic simply means stress. Sympathetic means my heart rate goes up, my blood pressure goes up, everything goes up, except for my digestion, which actually does a lot of weird things when I'm under chronic stress. So many, many, many of our patients, many of our friends, many of our family members, many of our neighbors, many of our strangers live in sympathetic. That's just where they are. That's where they'll stay. And that's going to keep us busy at the clinic. And that's fine because it is their choice. But once you step into my room and my office and my clinic, and my employees are doing the same thing, we're there to encourage you to be more aware of what your thoughts and thought patterns and behavior patterns and stress coping skills, and it goes beyond just, Mrs. Smith's got high blood pressure and her heart rate's through the roof, and she's like frail and thin, and she's eyes are bulging out, and she's a tweaker, but that's okay. She probably just needs a pill. She probably does, actually, but she probably needs more than that. So, and Mrs. Smith may actually be in her early 20s, not in her 70s. Okay. So we're seeing patients come in that are your age, that are college age students that are in their 20s and 30s, and 40s, that are going through a lot of have become autoimmune disorders because of sympathetic life, living in sympathetic world forever because of poor coping skills, because of post-traumatic stress disorder, because of trauma bonds, because of trauma hoarding. All of these things I talked about at the front end of this discussion are coming back here. And because this again is kind of where we are as a society. We take on every possible stimulus as a potential threat, as traumatic, as piggybacking on childhood traumas of things we maybe don't even know about, that have dictated our entire behavior up to this point. So these are the depths and the layers of health and wellness that we're currently dealing with. So anyway, consider what you are doing day in, day out. Consider how you perceive stimuli, how you perceive stress, how you cope with those stimuli, and how you compartmentalize and categorize and then behavioralize all of that stuff to the point of, is this healthy for me and those around me or not? And it can be that dualistic and that cut and dry. But generally speaking, you're probably in need of hydration. You probably need to cut back on some of the artificial stuff and some of the caffeine and whatever else it is that you're exposing yourself to that you think is going to be helpful in the long run to your well-being, because it's probably not. You might be feeding this, but you're not feeding this. So that at this point in your lives, you specifically, you seven or however many are in here, and whoever watches this video, your goals today and tomorrow while you're in school as a healthcare professional to be is definitely going to be thinking about your own health and how you approach health and what you do with that information and how you're going to grow and how you're going to be moving forward. So, sympathetic nervous system is the stress system. This is what's putting us into these chronic disease conditions. All of these metabolic syndromes, that lead to oftentimes autoimmune diseases, so, like lupus and MS, and then you've got, Cushing's and syndrome, and we're seeing a ton of Graves' disease with hyperthyroidism. It just POTS is another one we're seeing a lot of. Uh, you know, so until the system starts addressing the entire being and their entire existence leading up to them being in our exam room, we're just going to be chasing our tails, throwing pills at people. So, probably not the best way to go. So, it's important that you guys are here. You're at the cutting edge of change. And I've been in this business over 25 years. I've seen dramatic changes for the worse. I've seen dramatic changes for the better. And in the end, it kind of all evens out in the wash, it seems like. But at this point, because of the tools that we have and the technology that we have and the accessibility to information that we can use this as a benefit and not as something to be afraid of when it comes to promoting a healthier lifestyle. So anyway, nerve cells. We made it. Glue cells. So anyway, by the way, real quick, leaving it here. This autonomic nervous system. This is the bread and butter of what we're doing day in day out, both as a clinical professional and as just a human that exists. This is everything in the world to you and me and everybody else is stress and non-stress, imbalance, balance. Okay. Sympathetic is there as needed. It's not there as what's needed all the time. Sympathetic is there for those moments, which in a year, in a month, in a lifetime should be pretty minimal of quote unquote the bear jumping out at us, right? The bear chasing us. All of these things, these stimuli that send your body into a state of high blood pressure, high heart rate. Exercise does this, and it's another thing that we have to be careful of too, is choosing to put our bodies into sympathetic mode excessively. And that's a coping skill I'm seeing more now than ever. And this is this working out trend. There's nothing wrong with being physically fit. There's nothing wrong with going for walks. There's nothing wrong with going for a bike ride. There's nothing wrong with swimming. There's nothing wrong with hiking. There's nothing wrong with any of that. However, there is something wrong with the extreme nature of being in a fitness center and a gym, hours a day, 5 days, whatever days a week. And this extreme focus on some of this activity, this hyper fitness is actually doing just as much damage as doing nothing because what you're doing is triggering the sympathetic nervous system. You're purposely doing it. You're purposely saying, Bear, I am unleashing you and I'm going to run from you. Now start chasing me. And you're going to chase me for several miles. And then I'm going to hop on a bike. You're going to chase me some more. And then I'm going to jump in the water. You're going to chase me some more. And I'm going to do this every single day, day in, day out, day in, day out, day in, day out, day in, day out. And I'm going to think that's healthy. It's not. It never has been, and it never will be. No different than being a couch potato has never been healthy, has never been something that we need our society members to do, but yet they do it anyway. So what we're seeing is younger people going the opposite extreme with their coping skills from their traumas, and they saw their parents being lazy. They saw their grandparents maybe being obese. They saw a lot of type 2 diabetics. They saw themselves having maybe getting bullied in school, K through 12, maybe having low self-esteem. Then they get out of school, they're 18, 19, 20, 21, and they're going to go all out and hit the gym hard, and they're going to do the protein shakes, and they're going to start living that life, running from stuff, just to be bigger, fitter, stronger, faster, and ultimately more stressed out. So again, that's imbalance. We have to, as individuals, find a balance. Now, and again, I'm not ever gonna say don't don't be physically active. Okay, I'm also never gonna say don't sit on your ass all day either. So there's a and it's different each day for each person, each moment. So you have to let the body rest sometimes. Like today, it's 1,000 degrees out and high humidity, high temperature. This is not the day just because I do my run every Tuesday, no matter what, come hell or high water, I am running and getting my workout in outside. That's dumb and dangerous. And what you're doing is you're not just putting yourself at risk, but you're involving those who love you and concerned about you. Now you're getting potential EMTs and paramedics, and you're keeping them potentially busy because you chose to just not take it easy for one day, or to do your work inside. So that's what I mean. Just don't hone in on like this is the lifestyle I want to have, and I want to be a fitness guru that's going to be prepping for every thing on the planet that involves stressing out the body. Don't do it. It's just not healthy. It's consuming, right? It'll consume you. And it's really, frankly, just extremely egotistical. And we have enough ego maniacs running around that are unhealthy, physically fit. We don't need a bunch of physically fit egomaniacs running around too, because they're really not helping anybody but themselves. And really, they're hurting themselves and creating more work for everybody around them. So, but anyway, that's the trend I'm currently seeing among our young people. All right. I don't know if it's partly too because they were cooped up so bad during COVID. Again, most behaviors today are from traumas from the past. So I think why I'm seeing so many 18 to 25-year-olds blowing up the fitness scene and the gym is because from during COVID, when they were in grade school, junior high, and high school, they got isolated, and then they were forced to stay at home. They were forced to not be physically active. There were just a lot of restrictions, and that was very traumatic. And so now, that all these freedoms are back in play, they're able to, they want to go extreme so they can be, around a bunch of their buddies, around people they don't know, around potential like-minded people who want to just or they're pent up and they're frustrated, and they want to just get all that energy out, and so I think that's part of it too. But anyway, that's what I'm seeing and lately. It's in the last probably 6 months to a year. So getting into owning opening a fitness center and gym, with a pool and all the workout stuff and the rock climbing walls, and throw in some freaking martial arts and some MMA and jujitsu and shit, dude, you're gonna have people lining up. But is that really the route that we're trying to go here? Again, there's some self-awareness that needs to be done, and not go to these extremes to balance something that extreme that happened to you in your past. So anyway, yeah, that's another one. All these the dojo. seen is just, I mean, and that's just, those are just money grabs. They just lock you in. That's been known since the 70s and 80s. They were putting the hammer down on these dojos back then, Karate Kid and Cobra Kai, because they were locking people into these long-term contracts, taking their money, and it's one of those things. It's a fad, and so now we're seeing it again. It's everywhere on every freaking street corner, and all these dudes want to get sweaty and hug and roll around on the ground and pay a bunch of money each month. You know, uh, that doesn't make sense to me. Because the last thing you want to do if you're in the public eye and somebody's acting weird, last thing you want to do is be on the ground rolling around with them. You want to avoid them, and furthermore, you want to stay on your feet. So that stuff I'll never understand. Um, so, but again, that's extreme like trauma bonding, basically, and it's unhealthy. And they're usually covered in a lot of ink, which is also unhealthy. I'm seeing that now too. These autoimmune disorders that have skyrocketed, and these stress disorders we're seeing are also coming from folks who are getting extreme with ink, with tats, because again, you're literally triggering an immune response by penetrating your first line of immune defense. It makes zero sense, but it's a fad. It's trauma bonding. It's self-loathing. It's cool. Back in the day, it was like sailors and criminals, and biker gangs. The tough edge. Ugh. Now everybody's tough edge and got to show it off. Well, that's I'm telling you that comes back to roost. Decisions that we make yesterday and then end up today to back up those bad decisions then end up harming us in the future. So you got to keep that in mind. Everything you think, everything you do, it manifests. And so we want to keep our first line of defense from being penetrated. So yeah. Oh man. I've seen in 25 years in the clinic, the number of females between 18 and 40 with autoimmune diseases is just astounding. It's mind-blowing. As mind-blowing as the number of folks between 18 and 40 who are relying on dialysis now. I mean, these are issues that are lifestyle related, they're stress related, they're behavior related, and this is what you are encountering day in, day out in the clinical setting. So we're here to help. We're here to encourage. We're here to move forward with our patients and to really allow them the space and time and energy that they need to really focus on being healthy and what that means for them. So anyway, this is the future of medicine, is that more kind of whole organism. That's why we're seeing so many DOs integrated. 25 years ago, when I first started in medicine, and it's been more than 12, gosh, it's been like 27 now. Um, you a DO, doctor of osteopath was who the hell knew where to find one? And chiropractic 26 years ago, that was like witchcraft. Nobody's into that except for weirdos and people who just who think, lack of a back pop is why they got a hemorrhoid, So again, chiropractic has come a long way. Doctor of osteopaths have come a long way. Meanwhile, the medical doctors and that establishment is just kind of has been under a lot more scrutiny, as they should, because I'll tell you, their way of doing things for so many years has actually led to a lot more diseases and disorders. Um, so anyway, you guys are in for an awesome experience, and I'm so glad that you've chose to be in this medical industrial complex because we need you. We need individuals who are like-minded, who understand the process, and who are interested in the entire being. So yeah. So anyway, autonomic nervous system, man, this is truly the bread and butter of society, the bread and butter of life right here. This is everything to us. This is homeostasis, this slide right here. All right, so let's just get to some of the basics. Glio is nerve glue. Okay. there's the different types of glia. You can look at those. And neurons. So you have two cell types that make up the nervous system. It's either a neuron or it's a glue cell. Glia means glue. Okay. Wow, I can't believe it's 11 o'clock. All right. So glio means glue, neurons. Now, when you guys look at the neuron, you're going to see a couple of, here we go, a couple of basic features, nothing real crazy about it. But all neurons are going to have a nucleus. Yeah, so they're going to have a nucleus, and that nucleus is going to be contained in something called the cell body. Okay, so this neuron has a nucleus inside of the cell body. We can also see some mitochondria. There's definitely some rough ER there, some Golgi apparatus. Looks like probably some lysosomes and peroxisomes. So, fairly typical cell. There's cytoplasm in there. Um, they call this cell membrane. It's called a neurolemma. Like with muscle, they call it a sarcolemma. All right, but one thing about neurons is the cell body is going to have typically multiple little fingers and arms coming off of it, and it looks like a almost like a Pokemon bad guy or something right here. But anyway, you've got the dendrites coming off of the cell body, and typically a neuron will have multiple dendrites. Okay, so you can see there are multiple dendrites here, and that's typical of most neurons. This area where we call it the dendritic region is also what we call the input zone. So remember, neurons are composing nerves. Nerves are comprised of or composed of neurons, and these neurons are the wires, basically. So these are what are delivering information to and from the brain and spinal cord. All right, so they're going to be kind of like a wire. So you can have these little frayed bits of wire here, and then what we would have kind of coming in up over here would be another neuron, typically. Okay, so something would be connected. Another wire is going to be coming into each one of these. So as information comes from a different neuron, it heads over here to this one, and it's going to that would be called a synapse, where two neurons meet. So these dendrites are connected to the axon of a different neuron, more than likely. So all neurons, for the most part, are going to have dendrites and one single axon. Okay. Now we have what are called unipolar and bipolar and multipolar neurons, but for the most part, this is going to be a kind of your typical neuron. All right. So again, it's going to have a cell body, it's going to have an axon, and it's going to have multiple dendrites. The dendritic part is the input zone, and then this as a neuron is receiving information in this input zone, what ends up happening is we kind of collect that data. We add it all up. So they call it the summation zone. It kind of gets all that information gets funneled. So it's bringing it in here and then it gets funneled into here to the summation zone. This is also called the trigger zone. It's like a gun, a trigger zone. Okay, so the summation zone is where we're adding the information, all the stimuli. Now, that stimuli is coming in the form of electricity, so in the form of voltage, in fact. So depending on so there's a certain threshold at which the summation zone will enable or encourage the trigger to go off and the stimulus to perpetuate down the axon. So sometimes some of the stimuli that come into the neuron are going to be very weak. And so it's not going to be enough energy or electricity to perpetuate the original stimulus. So it'll just end right here. But a lot of times, as we get to what we call the threshold, they call it a threshold potential. Once we hit that threshold, then we can continue with the action potential down the axon. So once we get enough information coming in and the strength of stimulus is high enough and we've added everything up and summed it all up, then the trigger gets pulled and boom, we send that information down the axon, and then that's going to head. So this is called the conduction conduction zone. So we're going to conduct that electricity down the axon, and it's going to leave what we call the synaptic knobs. They also call this the axon terminal, the presynapse. So this is where the output zone is going to be, and that would be the output zone is where the neuron would plug in to potentially another neuron at the dendritic area, or it would plug into a muscle, so or a gland. And we would call this maybe like the neuromuscular junction. Eh. So anyhow, that is that for the neuron. So again, axon and then multiple dendrites typically. And again, multipolar, one axon and several dendrites. That's what that one is. Bipolar, one axon, one dendrite. There we go. I thought I had it. So multipolar is what we just looked at. And then we may have one that's got bipolars. It's got a pole here. It's got some dendrites up here. But one pole from those dendrites plugs into the cell body. And then we have a pseudo unipolar where you may have the cell body is kind of like off of the axon. So the dendrites and axons are connected. And then the cell body pops off of that. All right, and then we've looked at this, right? Afferent is sensory, efferent is motor. We do have in the spinal cord what are called interneurons. Inter means between. So between the sensory or afferent neuron, we might find a interneuron. And again, this is going to be in the spinal cord only. And what it does is basically is it encourages a response that doesn't have to travel all the way to the brain. So again, if we touch something sharp or hot or we need immediate response, stimulus gets picked up via the nerves, sent over to the spinal cord, and then you're going to have this interneuron there that's going to, basically connect directly that sense. So normally you're going to see these ascending tracks. So basically you're going to see these elevators that go up the spinal cord and bring that information up to the brain. We talked about that last week when we were doing when we dissected the brain, how these ascending tracks are bringing sensory and then descending brings motor. So, but in many instances, we don't need to involve those tracts right away to get a response. So we touch something hot or sharp, boom, get that interneuron involved, and then we're going to elicit some sort of response to pull away from the stimulus. And remember, pretty much all of what we're doing here is what we call negative feedback. So negative feedback opposes the stimulus. Okay? Negative feedback opposes the stimulus. Stimulus is hot. I want to oppose it. So I want to move my arm away from it. Walk into a bright room. Or today, maybe hopefully you're indoors, and then maybe after class, you're going to go outside. For some reason, it's really bright out. So the sun, the brightness, all that light is going to hit your pupils, and then your pupils are going to shrink. So you're going to, we don't need to bring all that light in. So again, stimulus response. Let's see. Oh, there's those tracks that I mentioned, ascending and descending. All right. Well, I think that's probably a good spot to stop. Yeah, 10 after. You guys have been doing great. Let's see. There was one. Let's see. Was that central? So again, central nervous system, brain, and spinal cord. We studied the coverings of the brain and spinal cord last week. We looked at the meninges. Remember, so you'll definitely want to look back into those. Dura mater, arachnoid mater, and pia mater. And then the spaces between and around those. Then take a little tour of the cerebrospinal fluid and those ventricles that we looked at as well last week. There's a nice illustration, three nice illustrations of kind of what those ventricles look like. Spinal cord structure, you have the dorsal root ganglion. This is sensory. So sensory comes in the back door, motor goes out the front. Okay, so nerve roots, the dorsal root is going to be sensory, the ventral root is motor. Let's see. Again, these are things we talked about. You can go through these again. I would highly recommend you'll need to anyway as you're doing your filling out uh, your unit lab assignment as well as doing your McGraw-Hill. So anyway, I'm going to leave it at that. I think the rest of this, like I say, is going to be details from last week, so you can go back through those. And let's see what else does this have. A little bit. Oh, I talk about the limbic system a little bit. But anyway, you can get the rest of this lecture on my course YouTube channel. So that's all I had today. Next week, I'm going to stop recording real quick. Beep, boop, beep.